Good morning, good afternoon, and evening, based on when this is viewed. I'm your host, Dr. Shumayou Dutta, and I'll be sharing an interesting case which raises the question: does minimally invasive decompression have a role in a patient with neglected adolescent idiopathic scoliosis com- and symptoms of severe stenosis? So, this is a lady who came to me with a known case of neglected AIS. She is now in her mid 60s, complaining of severe bilateral lower limb radiculopathy and left more than right. Symptoms are of neurogenic claudication. She can walk 2 minutes, barely walk 2 minutes, and then she'd have to sit down. And the pain scores in her leg was 10 out of 10 with a ODI of 78. She was intact neurologically. Her motors were 5 by 5 and sensory was intact. So this is her X-ray AP. You can see a severe scoliosis, and the lumbar curve itself is more than 60 degrees. These are the representative images of her MRI and CT scan. Here in the MRI scan, you can see a L45 severe stenosis, and both the lateral recesses are compressed. And in the CT scan, uh, you can see the CT scan level for the same. Now, this patient was also on osteoporosis for several years, and the bones you can see are sclerotic and very hard. So going through the rest of the images is very difficult to decipher from this or all the others because of the amount of severe degree of scoliosis present. So what would be the plan? Decompression and deformity correction. The patient has only come for her neurological symptoms of stenosis, and one option would be to decompress and to address the deformity at the same sitting. And would it be possible to even do a non-destabilizing decompression in such a patient? So this patient herself made the choice. She said she does not want anything to do with any implants. If something could be done minimally invasively, she was up for it. Otherwise, she would just rather continue with her symptoms. So I did a L45 microendoscopic decompression for her. Here you can see that the tube has been docked into the L45 disc space, and this is on the AP. Now working on the ipsilateral side, the angle is more than 45 degrees, and that's because of the amount of scoliosis and the rotation in the spine. And when we went over the top, it was more than 70 degrees, which presented a unique challenge of the instruments in my hand hitting the patient's body. Now, the surgery was uneventful. The ipsilateral decompression was done, followed by a contralateral decompression. Both the nerve roots were seen. The thecal sac was pressing against the concave side, and this is her post-op, a small little scar. She was mobilized out of the bed day 0, and her pain in the leg was immediately down to 1 out of 10. She was discharged in 24 hours. She came back 3 weeks post-op with no leg pain, and still complaining a little bit of back pain, but her leg pain was completely alleviated, and her ODI of 34. So definitely there is a role of a focal decompression, a non-destabilizing decompression in these cases also. It's like walking a tightrope where you have to be very stingy with the bony work while you have to be aggressive with the flavum work to ensure that these patients don't destabilize on table. The facets and the midline should be spared, and there should be minimal damage to paraspinal muscles. Basically, continuing on the line that everything inherent we want to maintain and everything pathological we want to remove. So MED in such cases was best suited. This is there may be a subset of patients with neglected AIS who can be spared from deformity correction and who will do well with just a focal targeted decompression. Thank you so much. I hope this was an interesting case.